Jerome B. Basang, MD, DPAFP, MHM, MBA. Dr. Basang practices in Cagayan de Oro City as a medical specialist 2 and division head of outpatient and aftercare program at the DOH Treatment and Rehabilitation Center and a clinical consultant for family medicine, diabetes and hypertension of Polymedic General Hospital. He is also a clinical associate professor, part-time, of Liceo de Cagayan University College of Medicine. He is a graduate of Doctor of Medicine at the Jose P. Rizal School of Medicine Xavier University, a graduate of Master in Hospital Management and Business Administration at Jose Rizal University. He is a diplomate of the Philippine Academy of Family Physicians, certified specialist of Philippine Society of Hypertension and ambulatory diabetes care practice at the Institute for Studies on Diabetes Foundation Incorporated. Among his organizational affiliations and position are the following: President, Philippine Academy of Family Physicians Misamis Oriental Chapter. President, Diabetes Philippines Cagayan de Oro Chapter. Board of Director, Misamis Oriental Medical Society. Member, European Association for the Study of Diabetes. He is also into research with presentations at the 2nd Annual Meeting of the Asian Association for the Study of Diabetes and 53rd Annual Meeting of the Japanese Diabetes Society in Okayama City, Japan, for the study entitled Impaired Fasting Glucose at the Northern Mindanao Medical Center, Impact Among Filipinos.
Good day, everyone. First of all, I would like to thank our friends from the Philippine Urological Association here in Mindanao for this opportunity for me to speak and talk on a topic that is very timely and very relevant in today's times, particularly in the advent of the universal health care. And that is on the topic family physicians and how our role in referring urology cases. So for my disclosure and the outline for today's talk, we will first review what family medicine as a specialty is, and then we will also touch on the family physicians and their role in the universal healthcare. And then we'll talk on 3 cases, which I personally handled and referred to a urology specialist. And then we'll do a recap or a summary of the talk. So what is family medicine? Well, it is a specialty in medicine that provides continuing and comprehensive health care for the individual and the family, encompassing all ages. So that's from birth to old age, and it also includes all genders by integrating biological, clinical, and behavioral sciences. So in essence, it is the center of primary care, and it is considered linchpins in the continuum of care. The scope of family practice is not defined by diagnosis, nor it is defined by organ systems, nor by procedures, but by human needs. Family physicians are trained in the biopsychosocial approach of healthcare management of patients. And this is because in family medicine, we believe that there is an interplay between the biopsychosocial factors. Some psychosocial factors can affect how the biological disease is handled or managed. And also the biological or the physical manifestation of the disease may also affect the psychosocial part of an individual. In the Philippines, the family physicians are members and are governed by the Philippine Academy of Family Physicians. What are the functions or roles of family medicine specialists? So basically, as I already mentioned, family medicine specialists care for patients regardless of age or health condition, and thereby sustaining an enduring and trusting relationship. There is also this role wherein family physicians understand community level factors and social determinants of health, because in essence, family physicians can also act as community organizers or even social mobilizers. Now, family physicians serve as a patient's first contact for health concerns. So they are the first contact medical care providers. One of the very important role, or one of the very important roles of family physicians is that of navigating the healthcare system along with the patient, including specialist and hospital care coordination and follow up. Now, this I highlighted this one because it is exactly this role where we get to talk as we go along with this lecture. We want to emphasize our position or our role in terms of navigating the healthcare system by referral to specialists such as our urologists. Now, family physicians also use data and technology to coordinate services and enhance care. And one of the most important role is that of a family physician's ability to consider the impact of health on a patient's family. Now, how about family physicians and the universal healthcare law? So recently on February 2019, our um, President Rodrigo Duterte, signed this landmark law, also known as the Universal Healthcare Law, or RA 11223. In this law, it contains comprehensive and progressive reforms that will ensure every Filipino is healthy, protected from health hazards and risks, and has access to affordable, quality, and readily available health service that is suitable to their needs. This also ensures that every Filipino should be able to access preventive, promotive, curative, rehabilitative, and palliative health services. So these part of the healthcare system, particularly the preventive and promotive aspect, is part of the training of every family physician. In the universal healthcare law, when we talk about it, there is what we call the primary care focus system. Now here, families and patients will have a primary care provider. The primary care provider under the universal healthcare law could either be a family physician or a generalist internist or a generalist pediatrician. So basically those who are accredited as primary care providers. And this will ensure that the frontline services are strengthened. And then family physicians, therefore, play a great role in the implementation of the universal healthcare law. The primary care providers or family physicians refer to specialists when patients need tertiary or a specialist level of care. That's when this is a very crucial role because um, this will enable the continuity of uh, medical care to a patient if he or she needs a specialist care. And that is why we are talking about this topic now. Now, once patients are treated by the specialist, they are then referred back to the primary care providers. So, having said that, we now talk on the cases that me personally, as a family physician, managed and had the opportunity to refer for specialist care of our urologist. So for case number one, we have FG, who is a 59-year-old female from Cagayan de Oro, who came in with a chief complaint of left flank pain. The history of present illness, 2 weeks prior to admission, the patient had onset of flank pain associated with fever and chills. She self-medicated with paracetamol that offered temporary lysis of fever. She also mentioned that her urine was cloudy, and she also self-medicated with cephalexin for 3 days, but offered no relief of the symptoms. The patient experienced persistent chills and high-grade fever, reaching about 39 degrees Celsius, and it prompted the outpatient consult with the family physician. At the outpatient, CBC and urinalysis were done. The WBC on CBC was 24,000 with neutrophilic predominance. And in urinalysis, there was pyuria. The random blood sugar was also tested, and it was 456 milligrams per deciliter. Upon review of past medical history, the patient is known diabetic and hypertensive for more than 5 years already. However, she was lost to follow up from her previous physician, and she is not currently taking any maintenance medications. So the patient was advised admission, and at the wards, there was workup for sepsis, and then she was started also on IV antibiotics. Her blood sugar was controlled by initiating insulin administration. And then I did some further workup to investigate on the cause of the infection. And a CT urogram was done. The impression on CT urogram was that of a left renal abscess, which measured um, 8.5 by 7.5 by 9.3 centimeters, infiltrating the perinephric space and the left psoas muscle. The psoas muscle lesion measured 7.6 centimeter by 2.6 centimeter by 4 centimeters. So because of this finding, I immediately referred the patient to a urologist. And upon further examination and evaluation, the patient underwent an ultrasound-guided drainage of the retroperitoneal abscess with pigtail catheter insertion. Eventually, the patient recovered and was discharged improved. Now, I took this from the PAFP website based on the Philippine clinical guidelines on the diagnosis and management of urinary tract infections among adults. With strong recommendation but with low quality of evidence, percutaneous drainage should be considered for renal and perirenal abscesses with sizes more than 5 centimeter. Open drainage should be considered for those with multiloculated abscesses and for those patients in whom percutaneous drainage is unsuccessful. Now, antibiotics should be given for a minimum of 4 weeks after drainage. So was what exactly was done to our patient. And eventually she recovered. She followed up with me with a relatively controlled diabetes. And she also followed up with the urologist. And with latest follow-up, the ultrasound, on ultrasound, the kidneys were all normal. For case number 2, we have EA, a 62-year-old female from Cagayan de Oro also, a known diabetic and hypertensive who came in with a chief complaint of hematuria. On HPI, the patient experienced on and off flank pain on the left side for several months already, but there was no consultation done. She just went on about her daily life until recently when the flank pain became more frequent. 3 days prior to consultation, the patient experienced flank pain again associated with occasional hematuria, and she described it as light red urine. Hence, it prompted outpatient consultation. The outpatient workup was also done. There was hematuria and pyuria on urinalysis. The blood pressure was elevated at 150 over 100 millimeters mercury. A random blood sugar was tested, and it revealed a 245 milligrams per deciliter result. The HbA1c was also determined at 8.7%. On CBC, the WBC was 16,000 with a predominance of neutrophils. And there was an elevation of the serum creatinine of 1.67 milligrams per dl. She was eventually admitted with an impression of an acute kidney injury secondary to acute pyelonephritis to consider nephrolithiasis and a diabetes type 2 uncontrolled. Now, at the wards, she was started on IV hydration. IV antibiotics was also um, started. There was pain control as well as a control in blood pressure and blood sugar. An ultrasound of the KUB was done and it showed shadowing echogenic structure occupying the left renal pelvis and mid to inferior calyces with a conglomerate measurement of 4 centimeters. The impression then was an obstructing nephrolithiasis on the left kidney and a simple renal cortical cyst on the right, based on ultrasound. So again, this patient, because of the ultrasound result of an obstructing nephrolithiasis and the patient was symptomatic, the patient was referred to a urologist and subsequently, with the control of infection, the control of the pain, the patient underwent percutaneous nephrolithotomy. The patient was eventually discharged, improved. And at present, the patient followed up. The serum creatinine became normal already. And then the blood sugar was improved from 8.7% HbA1c down to 6.9%. Now, based on the NICE guidelines for renal and ureteric stone management, patients who are 16 years or older that have renal stones that are larger than 20 millimeter, including a staghorn calculi, should be considered for PCNL or a percutaneous nephrolithotomy. This is exactly what was done to our patient. And basically, the guideline was followed since the stone was already 4 centimeter. The next case is that of a 67-year-old male. He is a retired bank executive from Cagayan de Oro, a known hypertensive, and came in at the outpatient with a chief complaint of urinary frequency. On history, the patient has had urinary frequency for several months, initially mild until it became more frequent. There was straining also while voiding, and there was dribbling. Your lower urinary tract symptoms were indeed noted. So because of this persistence, this prompted the patient to consult with his family physician. And at the outpatient consultation, IPSS score was 14, so that's roughly around moderate symptoms. And workup was done with an ultrasound finding of an enlarged prostate of about 30 grams estimated size. But the other findings were normal. PSA was done with 3 nanograms per ml result. The patient was prescribed with tamsulosin and dutasteride and was advised follow-up for possible referral to a urologist. However, the patient was lost to follow-up because of the pandemic. This happened during right before the pandemic. Now, the patient came back for consultation after 2 years from the last consult. Now, his chief complaint is hematuria. He claimed that he was lost to follow up because he felt relieved of the symptoms when he was maintaining on medications for 3 months, and also because of the pandemic. He came back because he noted recurrence of symptoms for at least a year now and noticed occasional gross hematuria along with other urinary symptoms. He also noticed weight loss. So eventually, the patient was worked up again, and the prostate size dramatically increased to 60 grams, as well as the PSA now at 12 nanograms per ml. The patient was then referred to a urologist for further evaluation and management, and subsequently the patient underwent surgical intervention and managed for prostate cancer. So According to the American Urological Association guideline statement, an initial trial of medical management over 4 weeks with an alpha blocker for or PDE5 and over 6 to 12 months with a 5 alpha reductase inhibitor is reasonable in men with bothersome lower urinary tract symptoms. A referral to a specialist who can offer additional workup and treatment options is recommended for men who either do not improve with medical management or have symptomatic improvement but intolerable medication-related side effects. Likewise, the Canadian Urological Association states that patients who experience a rising PSA after 6 to 12 months of 5-alpha reductase inhibitor therapy should be assessed for the possibility of high-grade prostate CA. So this was exactly what happened to our patient. So having went through all those cases, the 3 cases that we manage, what are the relationship between family physicians and specialist referrals? So as mentioned already in the previous slides, family physicians and primary care providers or primary care providers are the first contact medical care providers. On our end, as family physicians, we should be doing comprehensive evaluation of patients through history, physical examination, and even ordering laboratory or ancillary procedures to arrive at our diagnosis. And these are very, very important so that we will not be able to miss out on some other details that could have been missed out with our history. Now, in essence, family physicians serve as triage officers because since we are the first contact care provider, it is in our our role to facilitate and coordinate referrals for to appropriate specialties. So that is how important our role is in the provision of medical care to our patients. Timely and appropriate specialist referrals improve patient clinical outcomes and reduces medical care costs. There have already been a lot of studies to prove this, that as soon as, for as long as our referral is timely and appropriate, then we will be able to do away with unnecessary expenses on the part of our patient, especially as of this time, most of the expenses of our patients are out of pocket. And also, timely and effective referral ensures equitable access to specialist care. And under the Universal Healthcare Law, this is actually one of the goals, to be able to have an equitable access to specialist care through our primary care providers. So when does a family physician refer to a urologist? Well, I listed 4 general and very common conditions or situations wherein we as family physicians must refer to a urologist or to a specialist. One is when there is initial medical management or treatment failure. When, for example, what happened to our patient in case number 3, there was an initial apparent failure of initial management on the BPA, on his BPH. Hence, he was referred to a specialist. And true enough, the patient presented with progressive symptoms. And just like what I stated here, when patients present with progressive symptoms despite standard of care, then it is prudent for us to refer to a specialist. Number 2 is when there is a need for surgical intervention. Obviously, there are surgical interventions that need specialized training, and the urologist can perform specialized procedures that patients may need. So for example, in case number 1 and case number 2, the patient the patients underwent surgical procedures otherwise that are otherwise not conducted by a family physician or not done by a family physician. So this is another situation where we need to refer to a urologist. The third is when a patient shows signs of a more serious underlying disease that is beyond the scope of primary care or family practice, such as the possibility of malignancy. Going back to our third case, the patient presented with a red flag sign of hematuria in the presence of PPH. So to further evaluate the patient and evaluate for a possibility of malignancy, a referral to a urologist was done. And true enough, the patient had what do you call this? Had prostate cancer. And lastly, when there is a need for a patient to undergo further diagnostic evaluation that requires a lot of procedures or specialized procedures to evaluate and manage the patient's case. So I think these are the main situations where a family physician should be able to refer his patients or her patients to our friendly urologist. Now, having said that, family physicians should also follow through with their patients. It's not enough that we refer to a specialist. Our responsibility as primary care providers does not stop at referral to a specialist. Why? Because after the specialist care ends, our patients are referred back to us for continuity of care. So as I mentioned here, the family physician must be updated on the status of his or her patient's condition through collaborative efforts with the specialist because these patients will eventually be referred back after the specialist care ends. So in summary, we said that family physicians are at the forefront in primary care and that family physicians or generalists navigate the healthcare system with patients, including the referral to specialists, as well as hospital care coordination and follow-up. And lastly, a timely and effective referral by a family physician to a specialist improves clinical outcomes and prevent unnecessary waste of medical and financial resources. So with that, I would like to thank you all for your kind attention, and I hope that you will all have a pleasant day ahead of you. Thank you.